So cement or cementless total knee, I was tasked with answering this question. I'm not sure I'll be able to do that for you here in 10 minutes. Maybe I'll start the timer here, or not. But mainly because I don't use any cementless knees. So of the couple thousand of these I've done, I have 0 cementless devices implanted so far. But I'll see if I can give you a little history and maybe give you a little glimpse into the future as to where we might be going with cementless knees. Those are my disclosures. That doesn't really apply to this. So when you look at the history of total knee replacement, one of the very earliest cementless or designs was the Waldius hinge back in the 50s, and this was a cementless design that really failed for many reasons. The cementless nature of it probably was only one of them. When you get into the modern-day total knee arthroplasty, from the mid-'70s to the early '80s, pretty much all of the total knees were fixed to the bone with cement. This followed the John Charnley era, where bone cement was the panacea for arthroplasty. But there came this attractiveness to cementless fixation. It was kind of the early '80s, and one of my mentors, Charlie Yang, introduced cementless fixation to the total hip. And we wanted to try and avoid the cement fixation failure, thinking that there would be more durable fixation for the younger, more active patients. So in the early '80s, there were several designs, the first of which was the PCA knee that came out of Baltimore. Ken Krakow and David Hungerford designed the PCA, and it was really the first modern total knee prosthesis designed to be fixed without cement. They developed easy instrumentation. That was one of the hallmarks of the PCA. They improved the patellofemoral articulation as well as introduced some modularity. So this was one of the earliest cementless designs, and it did actually have success. Was kind of the first of its generation. There were several other surgeon champions that followed, including Leo Whitesides and Aaron Hoffman, who had their own designs that introduced cementless fixation. Come into the later '80s, where modularity was introduced or really furthered with the IB2, and it allowed some surgical flexibility, liner exchanges, and also allowed surgeons to provide supplemental fixation for the cementless design through the base plate. But now we started to see problems, and this came in the late '80s, early '90s. We saw these dramatic reports of osteolysis that started to surface, and it was really seen initially with some of the cementless designs. But these had problems other than being cementless, including the quality of the polyethylene, the processing, as well as the gamma radiation and air. And this is what was seen, not myself, but others with these major osteolytic lesions in these cementless cases. And here is Jerry Yang, who's one of my partners, who reported back in the early '90s with the early follow-up of a cementless design, where he saw 16% incidence of osteolysis that showed up by 3-year period. And it started to get attention, and it was the cementless design that took some of the hit for this. They postulated that maybe the cement could actually be protective to those interfaces. So maybe this was a feature of a cementless design that allowed the osteolysis to track through the screw tracks and get access to the bone. The outcome at that time frame was that the cementless designs took a fairly substantial hit because of the osteolysis, and it probably had nothing to do with the osteolysis. So we saw an increase in the cemented popularity. And then what followed was reports of osteolysis with cemented designs, such as this report from Mike O'Rourke and the group out of Iowa, where they reported a fairly substantial high rate of osteolysis. And they found that, there was really 2 surfaces where this polyethylene particles were being produced by. One was on the top side, which is the articular side, but also the back side. And that's probably where more of these small particles being generated caused these problems. And this was Jerry's report from the mid-'90s, where they saw 43% radiographic osteolysis resulting from this backside wear. And this actually won the Coventry Award, where he described the amount of backside wear in various contemporary designs. So we realize now that probably our early implication of cementless designs really wasn't the cementless design feature, but it was bad poly. It was the gamma radiation, it was shelf life, it was poor design and backside wear. So maybe now we can go back to the future and look back at the cementless fixation and see if there's a way to revisit this. Certainly, the idea of getting biologic fixation is attractive, especially for our younger patients. Maybe we can go revisit the idea of the non-modular tibia. Cement eventually can fail over the long run, and certainly our patients are getting younger and more active. So is it possible that with cementless designs we can revisit this successfully? Here's some of the requirements for cementless fixation. First of all, you have to have supportive host bone. We know when you look at the cementless surfaces, the porous surface, we think that the ingrowth potential, this was written 3 decades ago by Dennis Bobbin, is that 150 micron pore size. We think that bone grows into certain metals better than others, such as titanium and maybe tantalum. We need intimate contact between the metal surface and the bone, and this 92 paper showed that if you had a less than 50 micron space, you're more likely to get bone ingrowth. And you need good initial fixation, so you need to have absence of early micromotion. Well, what are the downsides? I mean, the knee implants are essentially surface replacements, so we know that if you're going to use a cementless device, you need to have precise cuts. And this study in 91 showed that there was up to 1.4 millimeters of variability between the peaks and valleys of the cuts that you make during your total knee replacement, and that's going to lead to early micromotion. Certainly osteolysis may be an issue if cement provides any protective effect to sealing those cancellous bony surfaces. And some patients we know won't get ingrowth. And if you look at the literature over the past few decades, and Tom Ferring wrote this paper about 10 years ago, where they showed 5% of patients failed to ingrow their cementless devices. And I think maybe the biggest disadvantage in today's market, where we're all looking at implant pricing, is the higher cost of these devices. When it comes to technique, you got to have precise bone cuts. You want to minimize bone necrosis with irrigation. You can use an autograft slurry, which has been shown to improve bony apposition. And it was Aaron Hoffman that showed us that if you're going to cut the tibial slope, you're better off cutting it anatomic to improve the load distribution and decrease the chance of anterior subsidence. So what about this porous tantalum? Certainly they entered the game first, probably now 10 years ago, and is this potentially a game changer for cementless, certainly tibial side, and maybe if they can figure out how to put it onto a cobalt chrome femur, we can do this on both sides. It has, as we know about tantalum, has high volume porosity, a low modulus of elasticity, high frictional characteristics, which can improve that early stability. And it seems to be very conducive to biologic fixation, physiologic load transfer, and great ingrowth properties. But it's still early in its evolution. There's now a fair number of articles that are written on porous tibias, especially with the tantalum. This was one of the earliest or most recent papers that I saw, which is at this this year's AAHKS meeting by Mike Meningini, where they looked at 100 consecutive cementless tantalum total knees, and they saw at 18-month follow-up a 7.5% failure rate, all of which failed from medial tibial collapse. And if they looked at the height and weight of their patients, they saw that the taller, larger males especially had a substantial increased rate of failure compared to those of the lighter patients. So I think that early fixation may be in question with these larger patients. So, cement or cementless, what are the pros and cons of each? Certainly cement currently would be the gold standard, and if you look at all of the literature over the course of the last 30 years, it outperforms cementless results in my opinion. You can get immediate fixation, you can deliver antibiotics, which a lot of us are doing routinely in our total knees, and it's less dependent on perfect bone cuts and bone quality. On the cementless, and it certainly is the more affordable of the two choices. Cementless is faster, and that makes it very attractive in my mind. There's no cement debris left behind, and we've seen, especially with MIS surgery, patients or surgeons leaving behind cement, which can become a problem. And certainly for the long run, especially for our younger patients, biologic fixation has certainly an upside. What about my interest? Like I said, I've put 0 of these in, although we're starting a prospective randomized study in the next few months. But I'm substantially interested because my patients are getting younger, and although the mean stays the same, the range of the number of 40 and 50-year-old patients that we're doing total knees on seems to increase each year. I think with hopefully improved metals and improved ingrowth surfaces, really all of the manufacturers are going to have some form of, whether it's a porous titanium or the tantalum, will maybe make the ingrowth and the results more predictable over time. And if I calculate in my OR on an average day where I do maybe 6 of these total knees a day, if each case cost me 10 minutes, and probably more really for cement prep and drying time, if I did that 6 times a day times 10 minutes, I could probably add the 30% productivity. And has already been outlined, I unfortunately don't have any interest in the surgery center, so I'm feeling a bit sad in the back of the room. But this may be one way to improve productivity, because, if you look at the projections, and Tom Farian has shown this, we all know this, Steve Kurtz and others, that by the year 2020, when I'll still be in the thick of my practice, the number of total joint replacements that we're going to be required to do to meet the demands of this population are going to be astronomical, and we're not really training any young joint replacement surgeons. We maybe have 50 applicants, 75 applicants a year for joint replacement fellowships. So if I can do more, I'll probably get paid less to do it, but maybe we can meet the demands for our population. Thank you very much.